we're delighted to welcome Alicia to PodChatLive. Thank you so much for getting up early and agreeing to this one. Title of the episode is Calcaneal apophysitis. And because Craig likes these things to try and get as much traffic as possible, we also want to call it Severs or Severs disease. We know that you did your PhD around the topic of calcaneal apophysitis, so we thought who better to get on and update us all with this condition. And we'd love to start with the topic or the debate about the naming, the nomenclature. Why should we be calling it Severs or Severs disease? Should we not? Should we care? Do we care enough? What's your take and your position on this currently?
Look, my main thing is about having a common language and making sure that no matter who we're talking to in the sense of a health professional, we're all talking about the same thing. So removing someone's personal name from it and calling it his actual presentation probably allows us to have those conversations. We were talking just a few minutes ago about the fact that using the word disease for a child can be quite confronting. So actually removing that component of it isn't a bad idea either. We were having a quick look at what the World Health Organization was saying, and they're actually saying to move away from calling things based on the person who apparently found it or discovered it or diagnosed it for the first time, move it more so towards what's actually presenting in front of you. So yeah, my thing is calcapophysitis. I do call it like that, and the kids all giggle and we have a chat about what it is, and it allows them to get some concept rather than thinking that they're going to die from some horrible disease.
Yeah, I mean, we should care about this. What seems like a trivial discussion, and some people have even referred to it as semantics. It's more than that. We should care. We should stop calling it Severs worldwide.
Yeah, it's the same thing. Things like your Island's disease, or I'm trying to think of some of the others that you might call us. It's a person. It's nothing to do with actually got no idea where it could be painful. So you could be talking to an orthopedic friend or a physio, and they'll look at you and go, "What on earth are you talking about?" It's a common language that we're trying to get to make a conversation easier.
Yeah, unfortunately, it's going to be a huge battle because I know all my daughter's friends at school. They all know what Severs disease is. You know, and it's going to be a challenge.
It'll be a generational thing. We'll move through.
When something's so easy to say as Severs and something less easy to say like calcaneal apophysitis, there's a hurdle there immediately, isn't there? But that shouldn't be a hurdle for us as medical professionals. That's obvious, isn't it?
No. Yeah. And look, allowing the kid to explain it as heel pain. It's as simple as that sometimes, because they don't know what they've got, and sometimes it can be not be calcapophysitis. Just sometimes heel pain in kids is just a good statement as well.
Yeah.
Actually, just on that, just before we started, I did a quick Google hunt around. I found this little article on the World Health Organization, and there's a paragraph down here about the naming of diseases. Oh, I've lost it.
There we go. Ooh.
Oh, damn, sorry. But it refers back to what we talked about with Mike Stewart about, here it is here. Disease names, the World Health Organization said, may not include geographic locations, people's names, species of animals or food, or references to culture, population, industry or occupation, and terms that incite undue fear. And I think that, that was that whole PodChatLive we did with Mike Stewart on the Nasibic language, and it's a really nice link there.
Yeah, a nice thing to move on to, given that you've said not all heel pain in a 10-year-old that presents is calcaneal apophysitis. Let's talk about sort of how we would clinically assess it. What features? I mean, is it something that is it's a barn or calcaneal apophysitis from the history alone? Is there ever imaging required? Are there special clinical tests? How would you sort of guide the undergrad or the non-experienced sort of pediatric practitioner into making those clinical decisions?
I personally think most of our practice as a clinician is what we hear rather than what we touch or what we see. A great history from an individual, it will give you probably 8 out of 10 times a diagnosis, or at least a working diagnosis, to head towards. So look, I tend to go clinically. I can only name a couple of times that I've used imaging to diagnose calcaneal apophysitis, and most of those times it's an exclusion for some of the other more complex conditions that could be presented. So no, what we know is that it will show up on an MRI, but what it won't show up is whether or not it's a painful component of the condition. It's not going to show necessarily on imaging that they're at a more painful period. Yes, they'll show you whether or not the growth plate's open, but it doesn't actually show you where they're sitting within that process. So no, I tend to do a medial and lateral compression squeeze. I tend to take it based on history. I rule out things like your juvenile idiopathic arthritises or enthesiopathies, your fractures, your bone tumours. They're the ones that I'm looking for, because at the end of the day, they're the ones that have the most disastrous outcome for a child and for that family. People talk about using ultrasound if they're lucky enough to have a machine in the clinic. It's not necessarily, once again, going to give you an answer that is reflective of the pain experienced.
Yeah. That comes back to history and examination, time and time again. Clear the red flags, take a good history.
Yeah, using things like your P-GALs, the simple, easy assessments that, once again, you should be using every day anyway. Yeah.
There's some sources that refer to it as an avascular necrosis. Is that appropriate? Is that accurate? And if not, how would you best describe what it is?
I wouldn't necessarily say it's an avascular necrosis. We're not talking about a loss of blood supply to an area when we talk about a true cause of an avascular necrosis. How do I describe it to a child in front of me? I often talk about their heel bone being in two pieces, like you have it as a growth plate, and we get out the bones and we talk about how it's going to one day come together, but each time they jump up and down, either the force of the ground or the pull of the muscle makes it sore. I think that's the nicest way of often explaining it to the little person in front of you, because we can talk about it all day and have all these big terms, but the little person is actually who you're caring the most about. So it's your ability to communicate. In a layman's term, we know in Australia we've got a health literacy rate of somewhere around a grade 5 level, so that's a 10 or 11-year-old. So assuming that they're going to have the understanding of what you're talking about, it isn't going to be there necessarily.
Sure. I often think back, think about, what is it? I often think back, I think it was 2004 or around 2005. I think it was from France, a paper that said it was a stress fracture of the metaphysis. And I remember thinking about it at the time. I thought, well, even if it wasn't a stress fracture, it's actually a nice way to think about it. Let's pretend it is a stress fracture and manage it like a stress fracture. Now, whether it is or is, I don't actually know, but I don't know what your thoughts are on that. Is it a stress fracture of the metaphysis?
Do I think it's a fracture? Probably not. Do I think it's a reaction to forces and to stress placed of an area? Sure. Yes. But I think the terminology fracture for a child, they associate it with it being broken. I like to always pull it back to the person in front of me. But we know that the stress or the strain that you place on that area causes more pain for the individual. So as long as we can explain it that way, it's not a bad way of saying it.
Yeah, well, I used to like pretending it was one and treat it like it was one, and it made a lot of sense at the time. I mean, but that was, I'm sure, mid-2000s. I mean, it was a long time ago, that paper,
Yeah. And I don't think we truly know what actually is happening in the sense of what is the cause. I think we've kind of moved to the treatment phase because we know it's a self-limiting condition, and we know that the outcomes is not looking long-term negative impacts for the child.
You might know where I'm heading with this question, but inflammation.
Yes.
We know there's a supplement that's widely touted for it that has extremely mild anti-inflammatory effects and nothing else, but I've never considered inflammation playing a very big role in it. I don't know what your thoughts are on that.
Oh, look, I wouldn't say visual swelling. If you see visual swelling with calcaneal apophysitis, I'd actually say it's not calcaneal apophysitis. Start thinking enthesiopathies. What we do know from some of the studies is that there is an edema at that area. So whether or not we're talking about inflammation or we're talking about edema at the bone level, I think there's two different things to talk about there. When we start talking about supplements, my thing would be, is there a component of placebo there in any component, at any point? It's such a mild anti-inflammatory, but then we still get a child to use ice. And we also, and I do too, I use ice quite a lot. And is that the placebo we're talking about, is the fact we're getting some pain relief as well from an ice. I don't necessarily think any of them are bad, but as long as you've explained to the person in front of you what the outcome is.
Yeah, but I just, on the ice, is that not a do something-ism?
Yeah.
Because if the apophysitis is deep inside the bone, there's no way the ice is going to affect that. But again, for those of you who are not familiar, the supplement that I was alluding to, I'll name it. It's called Oscon, OSCON. It's a widely touted supplement for severs. There is a website widely promoting it with an extraordinary number of testimonials. Absolutely amazing. I've even had hate mail for saying something negative about it from a mother who's fixed to her daughters. But again, placebo, natural history. The supplement does have extraordinarily mild anti-inflammatory effects. And if you look at their website, they claim that calcaneal apophysitis is inflammatory. But if it was, the NSAIDs would work really well.
Yeah. and that's often it. We talk about whether or not you would be, if you have your endorsement in Australia, you can use things like NSAIDs, and whether or not you would use it with calcaneal apophysitis. I haven't. I've used pain relief post an activity, but I wouldn't say I've used an NSAID actively to manage calcaneal apophysitis.
Yeah. No, it's like a lot of things.
We're trending towards talking about management here, which is obviously always the way we were going to go. And we've had a few questions coming beforehand about management, so we'll try and sort of break them down into individual components. The textbook way that we were taught in the UK sort of 18 years ago was sporty kid comes in, 10 years old, growth spurt at the same time as increase in activity. Bones grow quicker than soft tissues, so bones grow, soft tissues are left tight, and therefore we get this sort of equinus at the ankle. Therefore, what we need to do is several things: stretching of the posterior muscles, icing locally, and then things like heel raises or foot orthoses. So obviously we need to break these down and talk about them individually. First of all, can we just quickly talk about the presence or not of ankle equinus? Because obviously in one of those studies that you published, there wasn't actually that much equinus noted in the cohort of children, whereas in obviously a lot of other studies and historical sort of learning for all of us, we would make that assumption that there would be. Could you just explain what's going on there and why the difference between your research and other work? Yeah,
look, my thing would be, I was quite surprised about it too when it came out. I was assuming that, and I had always been treating with a stretch, not a post an active phase. It was even within our trial protocol, so it completely threw us around what we were expecting to see. But I think what we were probably one of the earlier ones to use to standardised measure, and to use something that had validated norms for children. So here we were all expecting to have this 10 degrees of dorsiflexion that we were testing it, however we were all individually testing it. But when we actually sat down and went, right, we're going to use a standardised measure, we're going to make sure we've got normative values for kids and actually see if these kids are presenting with a restricted range of motion at their ankle joint, because we're not talking about whether or not they've got range of motion, or we're talking about length of a muscle. We're talking about at that particular joint, what is the range of motion available at weight bearing. We were probably one of the early ones to also use a weight bearing measure. Lots of people were using measures, or not really giving us an example of how they were even taking the measure. They were just saying, oh, they've got 10 degrees of dorsiflexion or whatever magical number they've come up with. So that one was probably why we were finding a difference, and just encouraging people that while you may or may not be using a standard measure, just making sure that you're measuring it the same way each time the individual comes in is a starting point.
Actually, just on the range of motion, I know in my lectures, when I go back and look what I used to teach on severs, I always had the word, tight calf muscles. I always had a question mark after it.
Yeah.
But the reason I had a question mark there was you read quite regularly that tight calf muscles were common.
Yes.
But the data backing it up really wasn't there in any great depth.
Yeah.
But I also was concerned how much of it was splinting. When you try and dorsiflex them, it hurts, so they don't let you. So was there a false perception of the calf muscles being tight, therefore the false advice being given to stretch? I mean, that was the question mark I always had. But I think you've answered that, you know.
Yeah. And look, it's that moment of, if you're in an acute phase of pain and then someone puts me into a position that brings on that pain, of course I'm not going to stretch as far as I actually can.
Yeah.
That's a complete normal response.
Yeah.
So what's the closing comment on stretching as a part of the management of calcaneal apophysitis? Are we to do it, to not do it? Is it helpful, harmful? Does it matter or not? What's the part of
my thing would be to make sure that you're not using the good old template or script that you've got. Actually assess the child, make sure they've got range of motion that is normal or abnormal when you look at your normative values. You then have a think about whether or not stretching does anything at all. There's some really good, there's nice little Cochrane that's come out recently, where we're looking at the fact that there's not that great evidence for the outcomes of stretching. You're then going to implement a stretching program to a family that's struggling just to get to school on time, let alone brushing their teeth, and it's just another layer of complication. So if you don't think that they're that tight or that is going to make an outcome significant for the individual, why put another layer of stress for a family, would be my statement to that. I don't stretch anymore, especially if I've done my normal ranges of motion and it's coming back within normative values. I then have a look at the height and the weight of the individual. I think that's a component that's playing a component, maybe more so in Australia. I don't know what's happening in the UK, I'm sorry, around body weight in kids. We've got some kids that are looking on the heavier side of life at the moment. So having some of those brave conversations with parents around watching body weight with kids is something quite important. Quite a confronting conversation as a clinician to have, and we're not one that would treat it, putting it out there. We've got lots of referrals to happen from there.
When it comes to managing load, I mean, Craig just talked about let's treat it like a stress fracture or stress response. And in an adult, if we did that, one of the key components would be the load management, as it is of tendinopathy, etc.
Yep.
Load management in kids is obviously potentially more challenging, but actually, as we've spoken about, offline, they're pretty good at self-load management.
Yes.
I guess the first question I want to ask is there anything you actively advise, or do you just sort of let them guide the way? And the second part is rest. Is it appropriate at certain times, and if so, when? Complete rest.
Yeah. Look, I tend to find out what type of activities they're actually doing first, because you've got the child that does lots of sport for the day, and that's it. And you've got your budding athlete that's looking at 5 nights of training, 2 games on the weekend. They're the type of kids that you might have a conversation more so around load management. And then you've got the children that play non-stop in the playground at school. Their way to play and to engage is physically. Whether it be a little boy or a little girl, they might be the ones that climb the A-frames, that jump from the A-frame, and heaven forbid their heels get sore when you jump from a height. It's figuring out where their actual pain is coming from and what particular activities. I don't tend to remove them completely from a sporting activity. I still send them along to training. They may not be actively participating in the running component, but they can still do ball work. They can still do skill acquisition. It's still keeping them engaged in the physical activity. That becomes incredibly important. Most kids, if it's painful, will stop, or you know what, they won't, but it'll be sore later. They're actually really good at understanding consequences themselves. They're good at pulling things back. But yeah, my thing is figuring out, are they playing on an asphalt turf? We're still playing our netball on asphalt in places within Australia. And then you look at your basketball stadiums, whether or not they've got a sprung floor. Whether or not, my favourite one at the moment is the one from Sydney, who's been playing in footy boots on an AstroTurf base. It doesn't make any sense to me to be playing football in studs that are made for wet seasons on AstroTurf. That's just, there's those common sense moments that we're missing, or the family needs help finding, is more so around you. That's how you get your load management.
Yeah, I know, I mean, Alicia knows the story, but I never appreciated this whole concept of load management for it till my own daughter got the problem. And, I've been teaching severs and forever, and I did everything right to manage her, but no matter what I did, she still ran around the playground at school at lunchtime. No amount of pleading from me would stop her doing that. And it never, I'd done everything right. I did everything I know I should have done. The pain was so bad she would cry from it at times, but she would not stop running around with her friends at school. And I never really appreciated that whole load management side of the equation until then. And I'd like to think I knew what I was doing, but, obviously it really opened my eyes up.
And also understanding from both the parent and the child's perspective how bad the actual pain is during activity. I think a parent will do anything for a child. That's the way we're wired. But when you actually sit down, we use the Oxford Foot and Ankle Questionnaire in clinic and have a look at and put it in front of the parent and go, okay, so your child's only saying it's really mild or it's not really affecting them, but you're saying it's absolutely devastating because you guys are dealing with the consequences at 6 o'clock at night when you're trying to get dinner on and where everyone's crying and the world has changed and something else has gone down at school, but it's all catastrophized at that point in time. So that's the bit you remember. They've moved on 5 minutes later.
I've actually scribbled down a couple of times to remind myself to ask you, and now feels like a good time. The adult versus child, and what that note's saying to me. We could be talking about the way we describe it, the no-cebic language, the way we describe it, how we manage it, the load management. But we're obviously treating children, and in our pediatrics episode early on, we asked this same question as well. Treating the child versus treating the adult, so to speak. Clearly, from what you say, the adults are the ones probably at all stages through this that are more worried. Is that a fair comment?
Look, I think it is. I think that no one likes to see their child in pain. Everyone likes to think that their child is going to be the next David Beckham or going to be the next famous runner, and heaven forbid that they're not performing to their perceived best could be. Learning to the child to learn how to load manage or to manage their own pain or to even consider that there's an injury at play is not a bad thing. We just want to make sure that they have less pain and we manage symptoms to enable them to participate, and that being the most important thing. I don't think with calcapophysitis are you necessarily going to manage it and make them better. I actually think that's the self-limiting nature of the condition as they grow. I often get families come in and go, oh, it just flares up sometimes. Can you fix it? I can't fix it. It's a waiting game until that growth plate closes. But what we can do is make sure that it's manageable and they can continue to do what's important to them.
Here's one from left field. I vaguely recall a couple of papers from China about surgically fusing the growth plate.
Yeah, I saw that too and went, I don't know. Parents it's an interesting conversation because when you think about if a child's had pain, some of our kids had pain for going on 3 years that came into the study. If you've had a child that's only 11 years of age and had pain for 3 years of their life, it's a significant period of time, especially for a family member to watch them be in pain. So maybe they've headed down the surgical path because they've experienced it for a long time, but maybe it's also that they don't have the adjunct therapies or the allied health professionals to help out, and they've gone straight to a surgical option.
Yeah, it's bizarre, but yeah.
I've seen mentioned in some places the recommendation of shockwave therapy for calcaneal apophysitis. Now, to me, if we're talking about it like a stress response, I mean, that's certainly not something you do for a stress fracture. I mean,
good.
Have you come across these recommendations, and what are your thoughts on them?
Yeah, look, it's something when you guys, I have to admit, these guys gave me the heads up, and we have seen one individual in clinic who has had it as a therapy. It's something that we're seeing popped up, advertised on websites, and I kind of sit back and challenge the thought process of what you're trying to achieve. It's quite a painful experience. I haven't had it personally, but by reported and when you read it up, it seems to be quite painful. It's not something that I would probably advocate we would be doing, one, if we don't know what is the actual underlying cause of calcaneal apophysitis. We're kind of jumping to a therapy there that is quite painful and perceived to be quite invasive. If you wouldn't use it for a stress reaction and you wouldn't use it for a lot of other pathologies, it's not something I would be happy to be advocating for. And I have to admit, I get a bit grumpy when I get kids come in and talk about how painful it was. I think it's an unnecessary evil.
Mm-hmm. Yeah. Let's talk about foot orthoses. You know, one of the mainstays I remember being taught, along with your stretching, your icing and things, is orthoses, or at least some form of in-shoe intervention. Let's talk about heel lifts in a second. Let's just keep on orthoses. Prefabs, custom made, or actually just heel lifts. Let's talk about it now. What does the current evidence tell us? Because certainly when you look back over the literature, it's been pretty pro orthoses, and I've certainly seen some that's referred to having to be custom made, which is can be quite expensive for a growing child as well. What is the current evidence base? What is your latest work tell us about best practice there?
Look, what we found in the evidence was that our prefab device was just as effective or as a heel raise. So that basically the need, both had pain resolution with the interventions or had improved pain. So the need to jump to a custom orthotic probably isn't there if you can get the same outcome with a prefab device. It then comes down to whether or not we're going to think about the costs for families, and then we're going to think about the outcome that we're trying to achieve. If a child outgrows a device really, really quickly, a family member is probably going to be a lot happier knowing that it's a cheaper device to replace on a more readily or more often basis. That said, that using your clinical knowledge, using your clinical skills, and having a look at the foot posture and having a look at the individual in front of you, if a custom-made device is where it ends up going, it doesn't necessarily make it a wrong decision. It isn't just that the evidence right now isn't in front of you to support it being your first-line therapy. If you've got the child with a FPI of plus 12 and the prefab device isn't going to be enough support, then it makes sense to jump to it, but I wouldn't use it as a first-line therapy.
Now, I recall witnessing a discussion online about the height of heel raises used. Is there any, I think it was a 6 mil versus 8 mil debate with you and it may have been Miley actually.
Yeah, she stole them all. I didn't know they still existed.
they're all in the desk apparently. Is there we know that we don't have to be super prescriptive with these things in a lot of cases. So there's an envelope of success. So is it reasonable that for most children, if you pop in a 6 mil heel raise, that's a pretty good starting point? Or are there any clinical tests that can guide the sort of decision of that height a bit more accurately?
To be honest, it was what was readily available. Rather than making them yourself on the grinder. We used the 6 mil. Well, I thought we were all using the 6 mil heel lift in my clinic, but apparently someone had a stash of 8 mils. And then it's that question around, I'm also interested in how regularly you replace the heel lifts. That's the biggest downfall, I think, in our study was that we didn't replace the heel lifts after a period of time, the compression component, making sure that while the compression probably helps with not ensuring you don't end up with something like an equinus, heaven forbid, the horrible equinus that people rave about. But yeah, I think that's probably replacing the heel raise on a more regular basis becomes an important component of your therapy and probably means you're going to have more success with it in the sense of offloading that area. But do I think there needs to be a set mount? Probably not, but making sure that it's an even amount. What you put into the left, put into the right, rather than leaving them unbalanced. If you want to start heading up between a 1 centimetre, it does make a difference in giving them a leg length discrepancy. It's not something I probably want to be doing. Kind of like putting a leg on the right foot.
You'd always give bilateral heel raises, regardless, I assume.
Yeah, I do.
Worth mentioning.
Yeah, that would be my statement. We've had a couple come in and you kind of look and go, I I probably do both. Let's keep you even and see how we go.
Yeah, great. Where does footwear come into the discussion? Obviously, it's going to be sport specific, but
Yeah.
The daily footwear, you know, the one that they're in for 8 hours, 9 hours a day at school. I mean, do you find yourself having a lot of battles there? And is there a perfect shoe that could do it all for us in theory?
It's an interesting one. We did have a look at footwear, and we actually didn't find a difference between those that got given, and we were really Adidas Australia were incredibly generous, gave us a stack load of shoes to put on these children, and unfortunately for them it didn't show that it was any better for a child that was given a new runner. But what we didn't consider was the fact that a lot of the parents go and buy the purchased new shoes because they've done some Googling and found that the recommendation is to put a nice pair of footwear on. I think you've hit the nail on the head as being specific for the activity. I then come back to schools and often say they do so much running around at lunchtime and playtime. The standard Oxford school shoe, I don't think has a role in, especially in those younger children. It might, in the sense of your older teenager that doesn't really want to be outside at lunchtime playing. But then you've got your basketball kids that are doing. They're almost adults by the time they're 12, 13, 14. These males, they're heading towards being adults. You want to put them in a shoe that is supportive and is going to respond to the asphalt that they're likely to be playing on. I tend to put most of my kids in a runner. A lot of our primary school, a lot of our local government primary schools these days are happy for our children to be in runners at school. It means they don't need to swap in and out of shoes. It's one less cost for a family. And they perhaps even get a little bit longevity out of them as well. Great. Kids aren't dragging their toes along with the black leather they don't like to wear.
Yeah. Personal question. We refer to it as a self-limiting condition.
Yes.
What sort of timelines are we talking? Have we got any data on that? Obviously, all the things we're doing. I know Craig often likes the phrase, "These are the things we do to keep people occupied while the body does its thing."
Yes. Yeah.
What are the timelines of this if there was no intervention? Do we have such data?
We do know that as the growth plate opens earlier in puberty, so we know that girls go through puberty earlier than boys do. We know that they tend to have calcaneal apophysitis a year or two, a year and a half, a year before our males, kids that are presenting to the clinic. Makes sense that it then goes through on the tail end, meaning that boys are generally a little bit older as their growth plate closes. So we would expect them to see them having calcaneal apophysitis or the closure happening around that tail end of 13, 14 happening. I would like to think that it's about an 18 months, but we know from the study that we had kids that were in pain for 3 years. So I don't think there's a definite time period. I think it's sometimes having that conversation around puberty. We didn't include it within our study. I know we had a couple of people that were really keen for us to head down that pathway and think about how puberty was affecting it. I was a little bit nervous about having those conversations, probably a little bit more grown up now, and would have it comfortably with a parent. But back then I was a little bit nervous about engaging some of our families.
Actually, just on that, I can tell you my daughter's case. She actually hurt her hip and ended up on crutches for 3 months. The severs came right in about a month. So total non-weight bearing, it was about a month and it was all gone. We then had to worry about the hip. But just on that, we've just had a question, and I can never tell who this is. It's either Catherine or Stuart. They have the same account. But one of them has asked, are there any return to sport guidelines for these children?
My thing was I haven't taken them out of sport. I've tried to leave them in as much as they can, whether it's just that they're playing a quarter of the netball rather than the full game. I try to enable them to play at something. I think it's really important to keep them with their peers. I tend to ask them to play to a point of a pain level that they can't handle anymore, they're not comfortable. We tend to find out of 10 or a faces pain scale, at what point does it hit this face, what point does it hit this face, and the aiming to keep it below that 5 level or that middle of the range. The thing is that if you allow them to participate more, they will have more pain. I think measuring that pain becomes more so important than anything else. If you allow them if you make it feel a little bit better, you play harder. That is just the natural course of a child. So don't perceive that they're not getting better. The question is, how much more sport are they able to play in?
Yeah, no, thanks. Stuart's just replied it was him, so hi, Stuart. But I guess that raises the question that sort of Ian started alluding to before about, I'm with you, I've never tried to stop them, I've always tried to cut back, and I think it's important that they stay involved with the team. But it's the question is, sort of, should we even try and treat it? Should we just try and control it until it naturally goes away?
I think that's kind of what we're doing.
Yeah.
I think we're just controlling the pain and enabling them to participate and to continue on with what's important to them. Yeah. I don't think we are ever, and I don't know when you said that before, Craig, the heel pain magically went away. I went, yeah, I wonder if it was going to go away anyway.
Well, that's the other point too. What about and I know I've done this twice in my career. I've actually put them in a walking splint.
Yep.
Out of desperation, just to stop them from.
Yep.
I don't know whether the splint helped or not, but it stopped them participating in activity. When you've got to do it, you've got to do it. But have you ever done that?
I put someone in a ankle cam boot just to manage the pain and the symptoms that they're experiencing, mainly because the individual also refused to put their heel on the ground out of fear of pain. So it was more so managing the pain or the fear of pain, and then getting their heel down slowly with heel raisers within the cam walker, then moving them into a shoe with the heel raisers. I think it was more so managing the psychological perception of what the pain was impacting than actually the pain that they were experiencing. Little people, whether or not they end up with some of the more serious ongoing pain conditions, is what you're trying to avoid.
We've been asked this question. I'm always embarrassed to ask it. It's a horrible question to ask when someone like yourself has dedicated so many hours and years to understanding this, and then someone comes along and asks, is there a paper I can read that will just get me up to speed on this whole topic? I mean, I guess your PhD would be one of them. I mean, I know that you have published a lot of papers in this area. I know that between you and Kylie, you did that brilliant infographic.
That was going to be my suggestion. Just the infographic.
Yeah, I mean, obviously we can link to that under this video and things. But I mean, are there a couple of papers that people can read and really get up to speed with the nuts and bolts of everything we've been saying tonight? Yeah,
look, there's a couple of papers that are out there that more than happy to send through. Craig's probably already got them. There's a couple out. Perhamre, he's done some interesting work. Rolf out of University of South Australia, pre my work, did some great work as well. There probably needs to be here I go, dobbing yourself in here. There probably does need to be some kind of literature or narrative pulling it all together, because there's been some publications since the last one has come out. There's some great work coming out of Queensland QUT that they're going to continue the Calcaneal apophysitis journey for us. So they should be putting out some things shortly as well. There we go. Thanks, Craig. So yeah, I'm more than happy to send those through, load them all up, and yeah, anyone want to send through some questions, happy to take them as well. That's not a problem either.
That'd be perfect. We James has just mentioned that the infographic is on your Podiatric Special Advisory Group page, and actually it's a pretty reasonable time to plug that. Actually, if anyone's watching who is interested in paediatrics, or I mean, I don't see peds, but I'm a member of that group, and I probably learn more from that group than any other group on Facebook. So
yeah,
do you have to? It's not an open page. You have to request to be a member, I believe. Do you?
I believe so. I think James is the keeper of all secrets there. I'll be honest on that.
Maybe he could post a link to that group and underneath this as well, and hopefully people could join that group, because I know there's some incredibly good discussions on this topic and others there. Craig, anything else you want to talk about? Anything else that's come in?
I think that's there's the group.
Great.
I think we've covered. I think, and I've said this to Alicia before, when I was teaching at the uni, like every year you get your lectures ready, and Severs was one of those topics that I almost never updated, because there was never nothing to update it with. But a lot has happened in recent years, and I fully acknowledge that now, because we went for a very, very long time with, nothing was really changing, nothing in our understanding or management, but certainly a lot has changed in the last five or so years, and obviously based on a lot of your work.
Yeah, and look, I think the challenge to any clinician and we often hear this, why change if what I'm doing is working well? My challenge to those individuals is keeping relevant, because your patient is incredibly savvy. The mums have already Googled before they walk through the door. If there's a paper or an infographic, they've probably read it. Doing what you've always done just because you think it works is not necessarily keeping you relevant and to be the best individual you could be as a clinician.
But that doesn't also mean if you don't change, you don't do better.
No,
and
that's exactly.
Actually, I mean, there's still a lot of unanswered questions, and I know, again, Alicia, we've had this conversation before about, is it impact related or is it strain related from the Achilles? There's still a lot we don't know. It'd be nice to have an answer to that one, because
no pressure to the guys in Queensland.
Yeah, because if it was impact related, we just get everyone forefoot striking. No worries.
There might be a few concerns there, but sure.
Well, we'll give them more metatarsal stress fractures or something,
I mean, for me,
sorry,
go on, carry on.
No. I was just going to say that I can only hope that someone comes out with even better ideas, and that the stuff that we've done becomes irrelevant. That is the ultimate, is that the next generation comes through and finds something better for us.
Yeah. The take homes I've taken from this talk, and also I listened to your talk in Craig's online 24-hour conference, was you need to take an incredibly good history. You need to do an incredibly good examination. You need to clear the red flags. And once you're in that ballpark, if they're in good shoes with heel raises and you've just ploughed them with the appropriate education, parent and child, you're probably going to be okay. Stretching, icing, they're all kind of maybe might not do any harm, but they're, like you say, they're not really the keystones that I was taught they were 18 years ago. Is that summary? Am I on point there?
I think that's exactly right. And I think expecting them to be returning probably in a 3 or a 6 month period, I often say to families, before you come back, make sure that you haven't jumped back into your Dunlop volleys. Have a look. Do you need your heel raisers replaced before? They're easy, quick wins that the families could be doing before they come back. Because I honestly call it a bit of a roller coaster. I explain as a roller coaster to parents is that we go through these really bad periods. They come good for a while. We forget what we're meant to have been doing. They play a little bit harder. They go back and train 5 or 6 nights a week. And then, of course, the pain comes back. I think you will see them 2 or 3 times before the pain is completely resolved.
Great. And
it's just managing that.
Great. Well, I think that's probably a good time to finish. So thanks so much, Alicia. Sorry to everyone who was waiting live. We were a bit late started due to technical problems. Obviously, most people in Australia, I see quite a few Australians joining just in the last 10 minutes. So the whole thing will be live rendered and be available to watch. We'll have it on YouTube later. But I am extraordinarily impressed just how many people from the UK have been watching. Didn't you guys know that England's playing in football tonight? And if you didn't, they're up 1-0.
Great. No spoilers. I'm recording it.
Oh, sorry, Ian. It's only half time, so who knows what's going to happen in the second half. So again, thanks so much, Alicia. I think it's going to be valuable for everyone to watch. And thanks, Ian. My dogs are just starting to bark and make noises, so I think that's a good time to get off. So thanks, guys.
Thank you.